النهارده بيشرفنا مع اول سيشن استاذ دكتور شادي نبيل مشهور بيتكلم ان شاء الله النهارده على الهاي فلو فاسكولار مالفورميشنز وين اند هاو تو تريت. اتفضل دكتور شادي.
اولا احب اشكر طبعا استاذ الدكتور هشام الشيخ على الدعوه الكريمه دي من اسم الاشعه في جامعه بنها، وهي عزيزه جدا عليا، وان انا موجود في حضره استاذي الدكتور احمد فريد استاذ الدكتور راجب هاني، طبعا دي حاجه كبيره جدا بالنسبه لي. Our presentation today is about term اسمه high flow vascular malformations when and how to treat. High flow vascular malformations represent an arm of a larger disease spectrum known termed as vascular anomalies. In 1982 يعني في مجموعه من الاساتذه عملوا تقسيمه بتاعت مولكن وجلوفاسكي، قسموا الفاسكولار anomalies into two large entities: hemangiomas with a high rate of cellular turnover and vascular malformations. However, recently في society اسمها International Society of Study of Vascular Anomalies عملت classification in 2018 قسمتهم into vascular tumors و vascular malformations. vascular tumors منهم benign و locally aggressive و aggressive. اشهر البناين طبعا الانفانتايل هيمانجوما واخواتها. في حين الفاسكولار malformations متقسمه into simple, combined, major named vessels و associated with other anomalies. The simple are known as capillary, lymphatic malformations, disease of lymphatics, venous malformations, disease of veins, وال arteriovenous malformation fistulas or high flow vascular malformations. The combined combination of two or more in major named vessels زي البسايتيك artery وال associated other anomalies بقى combination مع other anomalies lipomatous hypertrophy, vascular organ anomalies etc. زي Klippel-Trenaunay syndrome و Sturge-Weber syndrome. The high flow vascular malformations consist of an artery, hypertrophied artery, feeding directly pouring into a vein without the intervening capillary bed. The communication may be of variable types, and we'll discuss the variable types later. Non-CNS AVMs can be found anywhere in the body, may be focal, diffuse, or combined with other malformations. How to evaluate AVMs? AVMs are rated first clinically. You have to see the patient as interventional radiologist. You're a clinical radiologist. You have to see the patient clinically. And then, once you have the clinical suspicion of an AVM, you go to radiological investigations. Primary, you start with an ultrasound and Doppler, and then if you confirm your diagnosis, you turn into an MRI, and then conventional angiography. The need of MR and CT angiography is very limited in these cases, and then and again we'll say why. And then you go to the clinical staging to decide whether this patient is a treatable patient, or you can conserve, or he is not a treatable patient. Classically, the ultrasound and Doppler show dilated feeding arteries and draining veins. The feeding arteries have a low resistance monophasic arterial flow, while the draining veins have pulsatile high flow within these veins. There are usually no soft tissue masses. If you find the high flow criteria of high flow and you do not have a soft tissue mass, you're talking about an AVM. If you have a soft tissue mass, tumoral tissue, then you're talking about a vascular tumor. MRI definitely is diagnostic. We see the serpinous signal void structures seen within the tissues, subcutaneous within the muscles, within an organ, within a bone. And usually they may have some fatty hypertrophy within the surrounding areas. When to treat is based on a classification called Schubinger Clinical Staging System for arteriovenous malformation, and it is a clinical and not a radiological classification. In the stage 1 or the quiescent stage, you have a simple bluish or pink discoloration of the skin, some warmth, and there is seen shunting on the Doppler ultrasound. These patients usually, unless they're in a critical location, we do not treat. You can conserve on this patient. Stage 2 is the stage of expansion, where you find the engorgement of the vessels, of the veins usually appearing. There's pulsatility, there is thrill, and there are tortuous veins starting to appear. And these cases may be conserved upon or may be treated depending on the location. If it's in a high-risk location, such as in a digital finger, very high risk of ischemia, it's not like being in the thigh or being in the upper arm or being in the pectoral area or being in the chest. It differs where the location is. In the stage of destruction, it's a stage of treatment. There are dystrophic skin changes. You have to see skin discoloration. You have bleeding. You have pain. You have ulcerations. You have a risk of infection. And these cases should be treated and are indicated for treatment. While in the stage of decompensation due to a long-term high flow and cardiac overload, these patients present with cardiac failure, and again, these patients are definitely indicated for treatment. The next step is to go for conventional angiography immediately, because conventional angiography identifies the angioarchitecture of the lesion, which means you see where the draining veins are, what the feeding arteries are, and there is if a nidus or not. And this differs in the approach to the lesion, whether it would be endovascular, whether it would be surgical, or a combined approach. In the most common classification used to guide the mode of treatment, we use the Rakes classification, in which there is a type 1, which is a direct one-to-one fistula between an artery and a vein. In type 2, you have a nidus intervening nidus. It means that the arteriole is draining into venules, which drain multiple veins and multiple arteries. Type A or B, depending on the outflow, whether it is multiple arteries, or there is multiple veins, or there is an aneurysm within the vein. Type 3 is a different entity in which the disease is in the wall of the vein. So we have a large venous sac, and you have either a single vein draining in type A or multiple draining veins in type B. Type 4 is a very complex type where it's occasionally called AVM en passage, where there are multiple, the arteries are minimally hypertrophied, and you have multiple feeding vessels intermingled within the tissue of the patient. So any occlusion of these vessels may cause increased risk of ischemia on this area. So this is an example of type 1, again a one-to-one fistula. The aim of treatment is to disconnect the site of fistula. This is the angiography, showing a hypertrophied artery from the external iliac artery draining into the external jugular vein, again a one-to-one fistula. The treatment in these cases is disconnection of the fistula. You can disconnect the fistula using simple surgical technique, or you can disconnect the fistula using coils, glue, or plugs. In this case, we used coils. This is after, showing the stages of flow within the hypertrophied artery. The other branches are starting to appear, and the vein is no longer draining the fistula. This is a very common site to see the type 1 malformations, is the pulmonary AVMs, is the pulmonary, what we call AVMs. Again, this is a simple one-to-one fistula, a hypertrophied artery draining into a hypertrophied vein, and then getting closer to the site to ensure that this is a one-to-one fistula. And then we conclude using what we call a vascular plug or Amplatzer plug, which blocks the site of the fistula. And once we do our control, we use another coil, loose coil, just to confirm that we have no more filling of the vein and stasis within the disease artery. This is a pre-CT for the patient. We see the hypertrophied artery going down in the vein, parallel to each other. And this is after 6 months. We only see the shadow of the plug or the occluder and the coils. Type 2, again, we usually see a nidus, multiple arteries draining into a nidus, what we call a nidus, arteriolar venule, and then draining into veins. This is the angiography. Again, very important, you see a nidus and multiple draining veins from the lesion. Again, this is a nidus. However, the shape of the nidus doesn't have to be a round. It can be an oval-shaped nidus. Okay? And then we can either treat these by directly injecting into the nidus, direct access to the nidus to opacify the nidus, and then we usually use glue in these cases. Some centers use alcohol, but in Egypt we usually use glue or another material called onyx. And then we fill the nidus using the glue to obliterate the vessels, or we can go a trans-arterial approach and again inject some glue to penetrate into the nidus with the trans-arterial approach. This is the before images, and this is the after images, showing a good devascularization of the lesion. The patient was later sent for surgery for aesthetic reconstruction. Very common type, again, to see in the uterine AVM types. We usually have this is a aortic angiogram. We usually see a nidus, again, multiple feeding arteries and multiple draining veins with a central nidus. The aim, again, is to occlude the core of the nidus. We go as deep as we can using a microcatheter. Again, we inject glue to feed into the deep as we can into the nidus, and preferably drain into the draining vein, proximal draining veins. This is the before. This is the after images. This is the patient was presenting with bleeding. This is the sagittal MRI T2. We can see the AVM nidus, again, signal void structures, serpinges, with the vein prolapsing into endometrium. This is after 6 months. A new MRI shows complete obliteration of the AVM. Type 3 is a different issue. Again, the malformation is within the wall of the vein. So we have multiple feeding arteries directly into a sac. Okay, this was a young guy, a boy, who was doing a tooth extraction. He started to develop severe bleeding, which was controlled. They did a CT angiogram. I believe it was unnecessary. However, we found a highly vascular enhancing sac within the mandible. We did an angiogram. We have a feeder from the alveolar artery and other perforators from the facial and lingual. We went first to do a selective angiogram, deeper angiogram. Again, we find the feeding artery, multiple small feeding arteries into the venous sac, and an aneurysm, a venous aneurysm with a single draining vein, molar vein. Again, it's the same presentation. We went first to control the arterial inflow because we were afraid that when we inject directly into the venous sac, the glue would run into the lungs. So we started to control the arterial inflow. After we injected the arterial flow, we were left with the perforators from the facial and lingual. We went directly into the sac. This is the angiogram showing again the single sac, filled it with glue, and this is the control showing a very good outcome with no opacification of the vein. Type 3B is different. Again, multiple draining veins. The pathology is within the sac of the vein, and multiple outflow veins. Again, the treatment is not a transarterial approach. It will be very difficult. So we usually go for a direct approach. This is you can see that all the vessels are converging towards the single venous sac. Once we inject the venous sac, we find the filling of the whole venous outflow, fill the sac with glue, and do a control angiogram before, and immediately after, showing a satisfactory result. This is very common in what we call cirrhoid aneurysms, usually in the scalp. The last type is type 4, very, very difficult to treat, very aggressive. The whole leg is infiltrated. You cannot discriminate between the tissue and the malformation. And usually the treatment we do is try to find the points of high flow, points of shunting, which causes the venous hypertension, mainly in the limbs, because this causes, again, symptoms of varicose veins with ulcerations, bleeding, and infection. Reduce the pressure as much as you can, and then send them to a wound care or someone to care for his wounds. This is what we can do. In summary, it is a difficult entity to treat with a high rate of recurrence, so we need a combined approach, endovascular and surgery. The patient education regarding out-of complications is very important. Only treat in the presence of symptoms, Schobinger 2 if safe, 3 and 4. And it is a multidisciplinary approach. Again, we usually do it in a combined manner between mainly the vascular surgeons and us. Occasionally, we can incorporate the dermatologists, we can incorporate the plastic surgeons, but mainly it's between us. And then the treatment option is based on the AVM architecture. How will you approach it? Is endovascular, direct, endovascular and surgery, direct and surgery, and whatnot. Thank you.
Thanks, Dr.